I'm Jane Newton, I'm a clinical specialist paediatric hypertension. As you said, as you said, I was going to talk about a local protocol we have incorporating standardised office BP with ABPM and echocardiogram to improve achievement in BP targets for patients with CKD. So we know ESCAPE showed us that lower BP is good for kidneys, and HeartKids showed us lower BP is good for the heart, and KDIGO changed their guidelines in 2024. But obviously achievement of blood pressure targets in the clinical setting is not always met, and integrating office BP and ABPM we know is the gold standard to achieve the BP targets, but we also had a goal to improve hypertension mediated organ change. So our local protocol, we use standardised office BP, which we defined as 3 blood pressures measured manually using auscultation. We used ABPM, and this is for patients with different stages of CKD. So we've split them into 3 groups: CKD stage 3 to 5, dialysis and transplant. And we did the echo within 3 months of the blood pressure assessment. So this is our local protocol. Basically, we did an initial blood pressure assessment with ABPM and categorised the patient depending on their 24-hour average BP to determine the frequency of their repeat ABPM. So on the left-hand side, if the blood pressure was within target, we repeated the ABPM at 1 to 2 years, depending on risk, and we've defined high risk at the bottom, or soon if clinically indicated. If the 24-hour average blood pressure was over the 90th centile, we were more proactive. We optimised BP control, a lot more manual blood pressures in clinics, titrated meds, and repeated the ABPM at 6 months just to reassess. We also made sure we get an echocardiogram, and if that echo shows LVH, we make sure that's repeated as well. The dialysis patients, just to mention, have a slightly different protocol. We do standardised office BP, ABPM and echo every 6 months as standard for them. So how is it achieved in clinical practice? So we have nurse-led hypertension clinics every week with a cardiac physiologist in the clinic doing the echoes. We also have nurses in the morning renal clinics for the transplant and CKD patients. So if they just need an ABPM, then that is done ad hoc, so it's not an extra appointment for them. We discuss all the results in the weekly hypertension MDT with the lead renal team for the patient and of course the family. We do formal letters with all the results on so that there's a clear plan communicated, and it also does help with engagement with the family with the plan. So I'm presenting data to report the differences between the baseline and the last assessment. We included patients who were in clinic over a 5-year period, aged 5 to 18 years, who had office BP and ABPM the same day. They had at least 2 BP evaluations, and both of those assessments were whilst in the same CKD group and at least 3 months apart. And we excluded them if there was no clinically valid ABPM. So we looked at 182 children, average age was 12 years, 55% boys, and a roughly equal distribution of patients within the CKD groups. So between baseline and the last assessment was an average of just over 18 months. There was no change in the height, weight, Z scores, but there was a drop in BMI Z scores. But that was actually seen across all the CKD groups. So this figure shows that the standardised office systolic BP Z score, the 24-hour average systolic, diastolic and mean Z score, all significantly improved between the baseline and the last assessment. Equally, if you look at them in separate CKD groups, you see the same trend with a drop in blood pressure between all 3 groups. So a subset of our patients had repeat echoes with the repeat BP assessments, and there was 107 children who had the repeat echo. It showed the LVH prevalence decreased significantly from 30% to 20% from baseline to the last assessment, and the indexed LV mass improved significantly, as shown by the graph. And the improvement in LVMI was also seen across the CKD groups if you break them down individually as well. So how did we do this? So there were more patients receiving antihypertensive medications and more patients receiving more than one agent. And just to note, the systolic BP at baseline was the strongest predictor for the change in systolic BP, allowing for those adjustments. So So in summary, integrating standardised office BP, ABPM and echo performed systematically can improve blood pressure and cardiovascular outcomes in CKD patients. Thank you for listening.
We'll give time for a couple of questions.
Of obstructive sleep apnea, and according to the American Academy of Sleep Medicine, pediatric OSA is defined as finding of one or more apnea or mixed apnea and hypopnea per hour, or other patterns of obstructive hypoventilation associated, for example, with snoring. So the obstructive sleep apnea is due to physical obstruction, despite the correct respiratory effort, is common in adult patients with different cardiovascular diseases and is associated with hypertension, coronary disease, stroke, atrial fibrillation, and heart failure. It's mostly, as I said, caused by upper airway collapse during sleep, and is linked to mostly to obesity, decreased muscle tone, and special anatomy of head. So the prevalence of obstructive sleep apnea in children is approximately 3%, so it's relatively common, but probably underdiagnosed in different groups of children. In childhood, the adenotonsillar hypertrophy is the most common cause of OSA in children, but obesity and also hypotonic neuromuscular diseases and craniofacial abnormalities are the other major risk factors. As we are well known from the studies in adults, the OSA in adults is connected with mostly with obesity and increased neck circumference, and as already mentioned, is common in different cardiovascular diseases. As we can see here on this picture, the polysomnography, the diagnostic tool of checking for the ASA in children, is possible even in small children. It's important because, as we can see here, there are many risk groups of children for OSA, and for example, there is a big group of children with Down syndrome which are especially prone to develop OSA, but also another group like children with craniofacial syndromes, with achondroplasia, mucopolysaccharidosis, with cerebral palsy, or different neuromuscular disorders. And prematurity is also a risk factor for developing obstructive sleep apnea. What are the symptoms? Of course, we all know that snoring is the leading symptom, but there are many different other symptoms of OSA, like difficulty in concentrating, frequent nighttime urination, morning headaches, or gasping. And what is more important, the symptoms differ according to the age of a child, and especially in small children, there are such non-specific symptoms of obstructive sleep apnea that it may be difficult to diagnose this disease in this group. As we can see, nocturnal sweating, failure to thrive, delayed development are the symptoms of OSA in infants. In older children are more like in adults, snoring, sleepwalking, but also morning headache or learning difficulties are symptoms of OSA. And what is the main pathomechanism of all these OSA-connected complications? And now the intermittent hypoxia is being recognized as this major pathomechanism, and especially the cycles of hypoxemia followed by reoxygenation, and which contribute to the development of this ischemia, reperfusion injury, and increased production of reactive oxygen species. And we learned already today that it causes different pathomechanisms which are connected with cardiovascular risk, like chronic inflammation, oxidative stress, decreased availability of nitric oxide, it causes the endothelial dysfunction, vasoconstriction, and is connected with different cardiovascular events, but also with metabolic changes. And for example, the insulin resistance and the increased activation of platelet is typical for the pathomechanisms connected with OSA. And all these pathomechanisms are also well-known pathomechanism of elevated blood pressure, but there are some also more typical for obstructive sleep apnea, like impaired quality of sleep or nocturnal fluid shift from legs into the head and neck. OSA is a well-known risk factor for hypertension in adult population, especially is the very prevalent risk for secondary hypertension, prevalent factor of secondary hypertension, and also for resistant hypertension in adult population. What we can also learn from the adult studies, in this meta-analysis it was shown that in the group of adult patients with obstructive sleep apnea, the hypertension was, the prevalence was 44% based on office blood pressure measurements, and when the ABPM was performed, the prevalence was 66%. So the ABPM is also the best method to diagnose hypertension in this group, because the nighttime blood pressure is also elevated, and this study also demonstrated that the prevalence of mask hypertension was 34% in the group with OSA. And this meta-analysis demonstrates that ABPM detects more hypertensive patients than office blood pressure because of this nighttime increase in blood pressure. When we check the possible pathomechanism of pediatric OSA, there are the same like in adults, so the same pathomechanisms are involved in the cardiovascular complication, and as we can see here, the oxidative stress, the endothelial dysfunction causes the increase in pulmonary vascular resistance and also in systemic vascular resistance, and the processes also cause the remodeling of left and right ventricular heart ventricle. So, what about the studies in childhood? In this group of almost 400 children with obstructive sleep apnea, it was shown that the hypertension was more prevalent in males, and was also more prevalent during late childhood and adolescence. So, and it is probably because of the obesity epidemic and the prevalence of obesity in adolescence group. And here we also see that in the group of obese children, more than half had hypertension. And with increased severity of obstructive sleep apnea, there is an increase in the prevalence of hypertension. So we have almost the same results than in adult studies. And what is also important to point out that desaturation, that hypoxemia is also significant as a risk factor for hypertension in the group of children with obstructive sleep apnea and in the group with significant hypoxemia, the prevalence of hypertension was also much higher than in the group without this significant hypoxemia. In another group, so in a group of children which were diagnosed because of elevated blood pressure, there was also a group with obstructive sleep apnea, and the authors pointed out that children with severe OSA had the prevalence of hypertension was 52%, but in this group there were mostly children with hypertension stage 2, so the severity of hypertension increased with severity of OSA. And this was also shown in a smaller group of 30 children, and 10 children had hypertension, but the apnea and hypopnea index with increased index, also the systolic and diastolic pressure increased in this group of children. In this study of almost 200 children, it was also shown that there is a significant correlance between systolic blood pressure and severity of obstructive sleep apnea. So with increased index, the systolic blood pressure during daytime and during nighttime also increased. I think for pediatric nephrologists, this study would be of interest because in this prospective study, the children with CKD stage 3 to 5 had performed polysomnography, and what is also shocking for me, 95%, so 21 from 22 had some degree of sleep disorder breathing. So and also what I wanted to show that in CKD stage 4, for example, the oxygen saturation was like 81. So this hypoxia was also shown in the patient with CKD. So maybe we should check our patients for OSA. In another study, it was also shown that OSA changes the regulation of circadian blood pressure, and the peak of blood pressure was earlier and was bigger in the group of children with OSA, and also in the group of children with different degree of sleep disorder breathing, in children with moderate to severe obstructive sleep apnea, the systolic, diastolic blood pressure and heart rate was higher than in children with primary snoring. And this was also shown in ABPM data in children with sleep disorder breathing, that severe OSA causes bigger blood pressure values, systolic, diastolic, and as we can see here also mean arterial pressure higher than in mild OSA or than in control, for almost all the parameters which were checked. And I would like also to show here that in children we also observe this desaturation like in that's connected with obstructive sleep apnea. So once again, the pathomechanism, the decreased oxygen delivery also influences the organ dysfunction. So the other well-known pathomechanism and also the saturation is important for developing of the cardiovascular complication. What are the possible treatment options? So in adults, it's mostly continuous positive airway pressure or oral appliances. Of course, life modification as a treatment tool for obesity. In children, as the first line therapy is the adenotonsillectomy, and even in obese children, it should be the first therapeutic procedure. And in persistent OSA in children, as the second choice is the and here on this picture, we can see how the positive airway pressure and this oral appliance, which pull the lower jaw forwards, open the airways. Here is the positive airway pressure, and here we can see the opening of airways by pulling the jaw. And is this treatment effective? We have the meta-analysis of the studies in adults, which shows that CPAP is effective in decreasing the blood pressure, the systolic blood pressure, and also diastolic blood pressure. So the decrease is maybe not so big, about 2 millimeter of mercurium for systolic and 1.27 for diastolic blood pressure when using CPAP. And the greater response was seen in younger adult patients, so below the 60 years of age, and with uncontrolled blood pressure at baseline. And in this group, the effect was -4 millimeter. And the biggest success or the biggest effect was seen in patients with severe oxygen desaturation. But in this group, this severe oxygen desaturation was below 77%. And in other studies, it was also shown that the CPAP treatment increases the nitric oxide availability and phlegmatic dilation, and decreases the production of pro-inflammatory cytokines. And what about the pediatric studies? There was one, I think, very interesting cohort study performed in Taiwan when the more than 25 adolescents were followed by 15 years, and as we can easily see, it was significant higher risk of major adverse cardiovascular events in adults who, as children, had the obstructive sleep apnea. It's really visible. And once again, as a summary, all the pathomechanisms connected with obstructive sleep apnea, like increased oxidative stress, inflammation, increased sympathetic nerve activation, insulin resistance, and increased activity of renin-angiotensin-aldosterone system, and decreased availability of nitric oxide, all contribute to higher blood pressure in this group. So in summary, the prevalence is 2%, but probably many children remain underdiagnosed, and the most common cause of OSA in children is adenotonsillar hypertrophy, but there are many other risk groups, and the intermittent hypoxia is potential major factor contributing to the pathogenesis of OSA-related comorbidities. And in my opinion, there is a need of multidisciplinary thinker to decrease the long-term consequences of OSA in childhood. Thank you very much for your attention.
Thank you, Dorota, for a beautiful educational overview talk about this neglected topic in pediatric hypertension, and we have 4 seconds for discussion. So, one question, okay?
Just to save our 4 seconds. Dorothy, quick question. So we know that CPAP helps, in adults. How about pediatric data? Like we always advise.
I'm not going to go over this again, but similar to the burden of cardiovascular disease and to the high rates of cardiovascular disease, we also know that the burden of chronic kidney disease is high, and almost 843 million of the population globally is affected by chronic kidney disease. What is interesting is that in the last 2 decades, chronic kidney disease has emerged as one of the leading causes of mortality worldwide. And thinking from the DOHAT framework as well, which I really like to share this figure when I talk about DOHAT, is to understand where we're going. We have to know from where we come. And I don't think I need to convince you that early childhood is a critical developmental time window. All the talks previously today highlighted this as well. But our work and others has shown that really this early childhood is really critical, and different exposure, including the growth trajectories in this critical developmental period, can detect, can show if an individual follows an ideal life course, an average life course, or a suboptimal life course. And the last two have been related to morbidity and disease later in life. Childhood growth trajectories capture dynamic changes during the child growth, and they may influence long-term cardiovascular, but also long-term health and kidney health. What is really lacking in the literature is relating these growth trajectories in early childhood with renal health and cardiometabolic health in children. So again, we utilize the data from the child cohort study, and I'll go a little bit more into detail on how the data was collected. So basically, we enrolled parents during the second trimester of pregnancy, and then we followed them up at the birth of their child. At 3 months of age, our child study staff went into our participants' house to collect different biological, different samples, including house dust. They like to clean their house, who is interested in that topic. But starting from since the child turned 1 year, at the 1, 3, 5, and 8, and currently we're completing the 13-year visit, we invited participants and the families to come in the clinic. So the main outcomes we have collected in the child study are related to asthma, allergies, infections, obesity, blood pressure, and we have expanded the cohort into mental health outcomes. We have collected detailed questionnaire data, and we have also linked to the largest environmental database we have in Canada, the CANO network. So in the child study, we have already derived BMI growth trajectories from birth to the age of 5. And this was done using height and weight and calculating the BMI Z-scores based on WHO age and sex reference growth standards, and we did use group-based trajectory modeling to identify the trajectory. So basically, we found a low stable growth trajectory, a normative in blue, a high stable in yellow, and a rapid growth trajectory. We measure systolic and diastolic blood pressure at the age of 8, and again, we use the last two measurements for the analysis. And we also estimated the glomerular filtration rate based on the Schwartz 2009 formula. In this slide, we show the distribution of systolic and diastolic blood pressure across these BMI growth trajectories. And what is interesting, we see that the higher systolic and the higher diastolic blood pressure are in the rapid growth trajectory, and that the difference across the categories was of statistical significance. When we look at the estimated glomerular filtration rate across the BMI growth trajectories, we see that the highest value, The lowest estimated glomerular filtration rate is in children that follow the rapid growth trajectory. However, across categories, this was not significant, but when comparing the rapid growth with the normative growth trajectories, that was statistically different. Taking these results further into regression analysis, where we compare the associations of low stable, high stable, and rapid growth with the normative growth trajectory, we see that children in the rapid growth trajectory had almost 4.8 millimeter mercury higher systolic blood pressure compared to the children in the normative growth trajectory, and they also had almost 1.9 high millimeter mercury diastolic blood pressure, which was independent of many prenatal and early childhood factors. Looking at the estimated glomerular filtration rate, we see that children in the rapid growth trajectory had almost -6. Okay, now the unit is a little bit tricky, milliliter per minute per 1.73 square meters, lower estimated glomerular filtration rate. So, in conclusion, early BMI growth patterns are associated with cardiovascular and kidney health, and the rapid growth BMI-Z trajectory from birth to the age of 5 is associated with consistently elevated blood pressure and reduced kidney function at the age of 8. So, these are important because integrating growth monitoring into pediatric care can aid in early identification of at-risk children and enhance early intervention efforts to mitigate long-term health risks. And I also wanted to highlight that longitudinal studies such as CHILD or other studies that were mentioned earlier are really invaluable for understanding life course health trajectories. I'd like to thank all of you for you might be familiar, some of you might be familiar with this graph from the WHO highlighting the causes that lead to the causes of death. And what you see is that cardiovascular disease is the leading cause of death. And actually, almost 18 million of global cardiovascular diseases are related to death each year. And out of them, almost 11 million are attributed due to high blood pressure. So we saw this figure a little earlier, and my work is really DOHA, the Developmental Origins of Health and Disease, where we heard about it today. And according to this DOHA framework, cardiovascular diseases or hypertension, high blood pressure usually have roots in early childhood. And we do see that the prevalence of childhood hypertension is increasing in the last decade. And in Canada, 1 in 25 Canadian children and youth are hypertensive. And when we look at the dietary risk factor, risk factors, dietary risks are the leading factors of hypertension, high blood pressure, and cardiovascular disease. But what specifically is included in these dietary risks? So we see high sodium, we see low whole grains, low legumes, low fruit, high red meat, high trans fat, low fiber, low vegetables, so low whole fruit, low nuts and seeds, high processed meats, high sweetened beverages, all of which are characteristics of ultra-processed foods. So what are ultra-processed foods? Ultra-processed foods are industrial food items that contain little to no whole foods due to the extensive processing. As you are aware, many of the foods sold in our food markets are heavily processed and industrialized. Industrial processes have improved food safety, extended shelf life, and ensured food security in areas where access to whole foods is not possible. However, on the flip side, some of these processing techniques, they fundamentally change the nature of the structure of the foods and can hike up energy density, but also leave out important nutrients due to processing. Ultra-processed foods have become a staple in the household. And in this graph that shows the global volumes of sales from 2002 to 2016, we note two main things. Firstly, there is no decrease, and there is no tendency in decreasing the global volume of sales of ultra-processed foods. And secondly, we see that the highest volumes of sales are in North America, Australia, and Western Europe. And when we look at ultra-processed food intakes in these regions, what is concerning is that children and adolescents, they have the highest consumption of ultra-processed foods. For example, in UK, 77% of daily energy intake, daily kilocalories, come for children and adults, and adolescents comes from ultra-processed foods, and is higher compared to adults. And the values are higher as well in Canada and in the United States. We recently published, this work was led from a PhD student in my team. We published data from the Canadian Child Cohort Study on ultra-processed food consumption and obesity development. The main things that we found was that at 3 years of age, again, 3 years of age, ultra-processed foods contributed to almost 35% of total daily energy intake. High ultra-processed food intake was associated with higher BMI-Z scores, waist-to-height ratio, and subscapular and tricep skin fold thickness, and also it was associated with 20% higher odds of living with overweight or obesity, primarily in males. And as I mentioned, this work was done in the Child Cohort Study, which is one of the largest and deeply phenotyped studies we have in Canada, with 4 sites across Canada, one in Vancouver, British Columbia, one in Edmonton, one in Winnipeg, and one in Toronto, the province of Ontario. We have enrolled almost 3,500 families, and we still continue to see them. So the data that I'm going to share with you today is on diet, ultra-processed food, and blood pressure, and it's almost in 1,412 participants. Diet was measured at the age of 3, and systolic and diastolic blood pressure was measured at the age of 8. And for this analysis, we used the average of the last 2 measurements. This is the 10-minute talk, the first one. So what did we find? Using the most common classification system for ultra-processed food, the NOVA classification, we found that at a 3-year-old, minimally processed foods such as the whole foods or fresh fruit, fresh vegetables, contributed to almost 39% of their daily energy intake, and ultra-processed foods contributed to almost 45% of their daily energy intake. When we look at the distribution of systolic blood pressure across the tertiles of ultra-processed foods, with the highest tertile being the largest amount of ultra-processed food, we see a tendency toward high values of systolic blood pressure, but this was not statistically significant when comparing the categories. However, the difference for diastolic blood pressure was of statistical significance, with higher diastolic blood pressure in the highest tertile of ultra-processed food consumption. Taking this analysis further into regression analysis, here we did mixed linear effect models, accounting for many potential prenatal, birth, and early childhood vectors, we did not find any association between ultra-processed food intake and systolic blood pressure. However, ultra-processed food intake was associated with higher diastolic blood pressure. And in the adjusted models, this difference was around 0.36 millimeter mercury. We looked further into the main common categories of ultra-processed foods, and what we did find is that bread and cereal, and also the ready-to-eat mixed dishes, which are characteristics of the Egg McMuffin, French fries, mac and cheese, higher consumption of ultra-processed food contributed from these subcategories was associated with higher systolic and higher diastolic blood pressure. But what we wanted to understand is that, can we reverse some of these effects of the high diastolic blood pressure? So we did feed a simulation analysis where we substituted 10% of the energy contributed from ultra-processed foods with minimally processed foods, so with the whole foods, with whole grains, fresh fruit and vegetable. And what we found is very interesting because substituting ultra-processed energy contributed from ultra-processed food with minimally processed foods was associated with 0.48 millimeter mercury lower diastolic blood pressure. I agree, some of you in the audience may say this might not be of clinical relevance. However, maybe in a population level data, this might have statistical meaningful. So these findings and also policy intervention previously in Chile, and Dr. Craig mentioned earlier policy intervention in South Africa, where we already see reduction on the main nutrients of concern, sugar, sodium, energy, the prevalence of obesity, and the cost related to a healthier cost is promising in terms of reducing the burden of ultra-processed foods. So in summary, ultra-processed foods consumption is high, and they are associated with higher diastolic blood pressure. Thank you.
Thank you. So we have time for one quick comment or question, or we could.
The many risk factors that leads to the development of hypertension in children, and it is a modifiable risk factor, and so important as a trigger for high blood pressure, potentially one that we can use to prevent the rise in blood pressure as kids get older. So what I'd like to cover is review the epidemiological data linking serum uric acid to childhood hypertension, discuss the relevant physiologic models that make hyperuricemia a biologically plausible mediator of hypertension, assess some clinical trial data, and then some practical recommendations. So starting with the epidemiology. This is a list of a number of older studies. You can see that they were published over 20 years ago for the most part. But what's relevant is that in all of them, and these were a variety of large studies looking at individuals who developed hypertension, that the pre-existent risk of hyperuricemia increased their risk for developing hypertension over 5 to 7 years by a factor of 1.5 up to 3 times. And this does include a pediatric population. The Bogalusa Heart Study saw this in 5 to 17-year-olds. And after this population, this series of studies, there were another 350 studies identifying this, that uric acid was associated with the future development of hypertension. And this is one of those later studies looking in a large group of patients in Taiwan and looking at various levels of serum uric acid. And you can see that the prevalence of hypertension was actually 6 times higher between the lowest and the highest serum uric acid group. It's not just elevated blood pressure. This is a look at a large study of adolescents from the NHANES data that uric acid correlates both with systolic and diastolic blood pressure elevation, but associates with elevated total cholesterol, triglycerides, and reduced HDL. So a whole array of different cardiovascular risk factors are linked to, not necessarily caused by, but linked to elevated serum uric acid. Taking a step back and looking at some hard endpoints, these are also from NHANES data looking over 50,000 individuals over several decades, that if you look at men or women, and the lighter the color is, the higher the quartile of serum uric acid, and you can see, just regardless of race or sex, that the higher your uric acid, the greater your risk for dying of a cardiovascular endpoint across the population. So elevated serum uric acid is associated with increased cardiovascular mortality. And then many of us are nephrologists, so very interested in what does uric acid look like in children. These are data from the CKID study looking at 627 individuals with chronic kidney disease ranging from CKD2 to CKD4 with 8 years of follow-up. And the prevalence of GFR decline to the next stage of CKD is much higher in the high uric acid group compared to the low uric acid group. So that is essentially a dose-dependent effect. So that's the epidemiology. Let's take a look at the physiology as to why on earth this is potentially relevant and useful to us. This is a study that was done by Rick Johnson, and this is in Sprague Dawley rats. And just taking a minute to set this up, this was a set of rats that were randomized to either a low-salt diet or a low-salt diet plus an inhibitor of uricase. So these rats on the pink line had high uric acid. They were treated that way for 6 weeks and then had a washout phase where they all remained on the low-salt diet for another 2 weeks. And then all of the rats were randomized to either a low-salt or a high-salt diet. Okay? So that's what was done. So in the weeks of hyperuricemia, we saw a 20 millimeter of mercury increase in systolic blood pressure. This was not seen in the control rats. And when you withdrew the hyperuricemia, the serum uric acid, the blood pressure converged on normal. However, the formerly hyperuricemic rats are now have a severe a sodium-sensitive hypertension phenotype that is not shared by the rats that were never hyperuricemic. The acute phase in blood pressure could be blocked by allopurinol, keeping the serum uric acid down, by RAS blockade, or by beta blockers. The chronic shift to sodium sensitivity could be blocked by the uric acid, either by allopurinol or uricose uric, or by blockade of MAP kinases or blockade of COX-2. That's kind of a summary of a huge number of studies that led to this physiologic pathway in which uric acid is taken up by endothelial cells through the URAT1 channel, activates MAP kinase, activates transcription factors NF-kappa B and AP1, that leads to the activation of COX-2, activating thromboxane A2, leading to the elaboration of platelet-derived growth factor, leading to vascular smooth muscle proliferation, and the elaboration of MCP1 that leads to macrophage infiltration of the perivascular areas, including the myocardium. So this is what uric acid in animal models does to the vasculature. Now, with that in hand, we developed a vascular model of uric acid-mediated hypertension based on these physiologic studies, in which there's an initial phase that there is reversible vasoconstriction. This is associated with an activation of the renin-angiotensin system and a decreased elaboration of nitric oxide. And this phase is uric acid dependent, so you lower uric acid and the blood pressure comes down, and not responsive to sodium. After arterial or wall thickening associated with the platelet-derived growth factor, you lose compliance of the vascular smooth muscle, and this becomes uric acid independent, permanent changes in the vasculature, and this is sodium-sensitive hypertension. Okay. Is there any overlap in humans? Well, this is a look at the Framingham cohort and separated into quartiles of serum uric acid, and individuals with higher uric acid have an associated loss of vascular compliance based on pulse rate velocity. So consistent, again, not proof. So why is the uric acid high in some of our kids? Well, I think there are a number of genetic driving mechanisms, but I think this is a critically important issue in terms of a modifiable risk factor, and that is fructose intake. If you remember back to medical school, you learned that glucose is, glucolysis is activated by hexokinase, and that hexokinase has feedback inhibition, so that if you deplete ATP to ADP or have fructose 6 kinase, then the whole system shuts down. That's not true of fructose. So if you feed cells fructose, they're going to metabolize the fructose until they run out of fructose. No feedback inhibition whatsoever. And so that's going to cause a depletion of ATP to ADP and down to AMP, and activation of purine disposal pathways that lead to uric acid production. So your patients who are consuming large quantities of sugar-sweetened beverages are doing this every day. Is this relevant? Well, this was a study that was done on a population of about 200 young men where they were fed 200 grams of fructose a day for 2 weeks. And what happened to their metabolism? Their triglycerides went up. They didn't have enough time for them to gain much weight, but they did have an increase in blood pressure, both systolic and diastolic, and their serum uric acid raised by a milligram per deciliter in just 2 weeks. Withdrawal of the fructose resulted in normalization of all of these. So fructose is a reversible mechanism by which you can cause hyperuricemia in a real way. And in the NHANES data, we saw that 2 servings of sugar-sweetened beverages per day is associated with a rise in serum uric acid of 1 milligram per deciliter. So clinically relevant. So let's look at some clinical trials. So this was the first trial that we looked at in terms of reduction of serum uric acid in hypertensive adolescents. And what we did here was we identified 30 kids with stage 1 primary hypertension and a serum uric acid above 6.0 milligrams per deciliter. We randomized them to 2 groups of 15, treated one with placebo and one with allopurinol, measured their blood pressure by ambulatory blood pressure monitoring, and then crossed over so that they were their own controls. And what we saw is while these patients were on allopurinol, 27 of 30 normalized their blood pressure, and whereas on placebo, only 1 normalized blood pressure. Because there were concerns that allopurinol as a xanthine oxidase inhibitor might have some pleiotropic effects, we then followed this study up with a randomized controlled trial of prehypertensive adolescents and randomized them to allopurinol, probenecid, a uricose uric, so looking at a different mechanism of urate lowering therapy versus placebo. And similar to the previous study, these individuals, regardless of their mechanism of urate lowering, lowered their blood pressure by about 6 to 7 millimeters of mercury, both systolic and diastolic. So this is a uric acid effect, not a xanthine oxidase inhibitor. Francescati and colleagues looked at another 52 adolescents and randomized kids with stage 1 hypertension and elevated serum uric acid to enalapril or enalapril plus allopurinol. And what they saw is that there was an additive effect of RAS blockade and urate lowering therapy on ambulatory blood pressure monitoring after 8 weeks of therapy. And this was a meta-analysis that was more recently published looking at 11 randomized controlled trials using febuxostat, which is a more recently released xanthine oxidase inhibitor. And the endpoints were blood pressure and GFR. These were, again, adolescents to young adults. And across this meta-analysis, you can see that the use of urate-lowering therapy favored lower blood pressure and actually increased GFR. So now we have 14 studies that are positive for urate-lowering therapy and blood pressure reduction. Now, this is not universal. This was a fantastically well-designed study by John Foreman and colleagues that essentially paralleled the second study that our group did, but in older individuals. And he's looked at 150 patients, mean age of 41, mean serum uric acid was 6.1, but of note, that meant that half of the patients actually had uric acid in the normal range. Their blood pressures at the beginning of the study were entirely normal, and there was no change in blood pressure with urate-lowering therapy. So what's the difference? Well, this is a much older population. They were normotensive at the start. Only half of them actually had ambulatory blood pressure monitoring. They were less hyperuricemic, and most of them were smokers. In fact, 96% were smokers. So they had other confounders that may have been causing activation of other pathways that were not relevant to uric acid. Many of us are familiar with SGLT2 inhibitors and the tremendously effective impact on cardiovascular risk. You can see that the dramatic reduction in cardiovascular mortality seen in the EMPA-REG trial. But of note that was less publicized is there's a dose-responsive urate lowering effect of SGLT2 inhibitors. This is across the entire class. They cause reduction of about 1.5 milligrams per deciliter at commonly used doses. So the summary of the clinical trial data is that elevated serum uric acid appears to have a greater impact on blood pressure on young individuals and those with fewer CV risk factors, fewer confounders. Urate-lowering therapy, independent of mechanism, may lower blood pressure in adolescents in a magnitude similar to a single conventional antihypertensive medication. Uric acid reduction through the restriction of fructose intake may have promise in blood pressure control. And all of this is consistent to that original two-phase impact of uric acid on blood pressure, initially a vasoconstrictive phase that becomes a permanent vascular remodeling. And the potential impact involvement of uric acid in AKI is completely on this scope of this talk, but a fascinating one, which we can talk about in breaks. So practical recommendations in terms of uric acid management. Universal medication management is not supported by the data because more conventional, more safe antihypertensive medications are available. But if you have clinical gout, xanthine oxidase inhibitors that make sense. If you have a very elevated serum uric acid on the order of 10 milligrams per deciliter, it still makes sense to use urate-lowering therapy. And dietary management of hyperuricemia, particularly low fructose, may have an important salutary impact on blood pressure. And just to remind you that this is not new, this was a treatise that was published in 1896 by Alexander Hayes at Guy's Hospital in London. Uric acid is a factor of causation of disease. The pathology of high arterial tension, headache, epilepsy, mental depression, gout, rheumatism, diabetes, Bright's disease, and other disorders in a mere 572 pages. Thank you very much for your time.
Thank you so much. I'm convinced that I have to treat uric acid. So, any questions?
Then can you comment on the result of
He's not only a consultant, he's also recently became professor, and he's very well known, I think, for his research work and his newest publications, the last RCT on blood pressure levels. So, please.
Thank you, Stella, for the kind introduction. Thankfully, none of you have looked at the online pictures which introduced the speakers. I particularly look very grumpy in that. I think that was because of sunshine in your eyes. So I've been given this topic, and I'm really grateful to the scientific committee for including this. And over the next 15 minutes or so, I'm going to discuss some cardiovascular properties that determine blood pressure in children and of course in adults, and try and discuss the phenotype of hypertension we see across the age spectrum, and try and compare and contradistinct them between the young adults, the older adults, and children and adolescents. Highlight some key recent work which brings back these things about where is the data, and then perhaps consider some clinical relevance and potential future research directions. So a lot to consider. So I'm sure you've all seen this figure before. So this is a recent systematic review from numerous studies worldwide, which gives us the prevalence of primary hypertension across childhood populations. And what's quite striking about this is that over the past 3 decades, if you look at the decade which was the oldest, and it's on the line at the bottom, and you can see the prevalence rates have climbed. They've climbed across the age spectrum, with a peak which has happened during adolescence. But essentially, over the past 3 decades, there's a 5-fold increase in the prevalence of hypertension during childhood, which mirrors somewhat the increase in childhood obesity. Now, it is quite striking that, I think balanced with our knowledge already about tracking of blood pressure, which is very well understood, it does need some consideration. So, if the prevalence of blood pressure was 0.5% and 1%, then adult colleagues would not quite worry that much about the children who have had childhood onset blood pressure then becoming adults with high blood pressure. But if it's a 6% increase, then there is a tsunami of young adults who've had childhood onset high blood pressure, which is coming into their clinics, with the adverse cardiovascular outcomes that come with that. And that's very well shown in this data from Rahul, who's in the audience and presenting tomorrow, which looks at a population-based study from Ontario, and shows that there are major adverse cardiovascular events, hard outcomes, including mortality in these children who have hypertension, a twofold increased risk over the next 12 years median follow-up when you compare them to normotensive age-matched peers. So, it's really sobering data, and it's important for us to therefore really take note of the high blood pressure and the rates and the trends that are occurring. To consider the phenotype of hypertension, I think it's been known for quite some time. I show you one very important study from Professor Sorov showing that the predominant phenotype of hypertension during childhood is isolated systolic, and that's been shown in a sort of early adolescent population of school children, mixed ethnicity, and very carefully considered, and that was found in 9 out of 10. And then they also made some additional that the BMI was higher in those who were hypertensive, and these are 25-year-old data, but additionally, showing that there is an increased heart rate in the hypertensive, but particularly so in the obese hypertensive, suggesting this hyperkinetic aspect, hemodynamic state in these children. And therefore, the suggestion that there is an increase in the sympathetic nervous system activity which may be driving this state. And if you consider the other phenotype, isolated diastolic hypertension, there are considerably fewer patients in that. So this data set from the NHANES data shows that this is about 1/5 to 1/10 of the prevalence rates for isolated systolic. So it's a way, it's much lesser, but it's also quite interesting phenotype. They're likely to be girls, they're likely to be younger, leaner, and white Caucasian. And we don't quite understand the phenotype very well, and certainly the hemodynamics of that very well. And when you look at that, we're quite used to working in silos, and if you look at what is the phenotype of hypertension across the adult age spectrum, you can see the dark black, which is the isolated systolic, is really limited to the elderly, in their 7th and 8th decade, whereas the predominant form of hypertension for the young adults, and mostly around 40 years, is isolated diastolic hypertension. And that is quite different to when you contrast these sort of data. So these data, when you look at it in this, across the whole age spectrum, do suggest that the hemodynamics of primary hypertension are likely to be quite different across the age spectrum. And so let's look at the data of this hyperdynamic state in children and young people, and I call young people children, adolescents, and young adults, sadly, those who are under 30 and 35, so I definitely don't qualify. So this is a study from Cambridge in UK, looking at college-going students, around just over 1,000 of them, and hypertension rates were about 12%, 2/3 of them had isolated systolic hypertension. If you look at their blood pressures, there was a 30 millimeter difference between the normotensive and those who had isolated systolic hypertension. The average age is 20. Most of them are men. They are taller. They are overweight. But there's no difference in the heart rates between these patients who have systolic hypertension compared to normotensive. But if you look at their other hemodynamics, they do have an increase in stroke volume. They have an increase in cardiac output. But interestingly, no difference in their systemic vascular resistance, and very minimal change in their pulse wave velocity, the carotid femoral pulse wave velocity, and actually no difference in their distensibility or augmentation index. We recently performed a meta-analysis of looking at all the studies that have reported and compared normotensive and hypertensive patients across the age spectrum. And I show you these forest plots for you. On the left top panel is cardiac output. There's then the heart rate. On the bottom panel, there's a stroke volume and there's systemic vascular resistance, with children and young adults being shown in red. And what you can see is there is an increase in cardiac output when you look at these hypertensive children and young adults compared to normal, increase in cardiac output, in heart rate and stroke volume, but not in systemic vascular resistance, which is quite different to that found in adults, where you see an increase both in cardiac output, but also of systemic vascular resistance. And actually, if you look at the difference, there is an increase in both cardiac output and systemic vascular resistance, but the relative increase in cardiac output is way lesser in the adults, older adults compared to the younger ones, and most of the increase relates to the increase in systemic vascular resistance. And so the main hemodynamic alteration we are seeing in these primary hypertensives is an elevation of cardiac output initially from these data. There are some differences by sex. So these data from, again, the ENIGMA cohort, now slightly older, about 8 years older, slightly more enriched, about 3,000. And you can see that for boys, there is, or men should I say, there's an increase in cardiac output, which is associated with an increase in stroke volume. But for girls, it's mostly an increase in the systemic vascular resistance and heart rate, suggesting that there may be differences between the sexes in terms of how the hemodynamics function for them. And there are some data which contradict these findings. They don't necessarily sit so cleanly between cardiac output and systemic vascular resistance, and this is some data from the ALSPAC data set, which have shown the hemodynamic variables of interest, so stroke volume, heart rate, and peripheral vascular resistance on your left-hand side, and show that with increasing blood pressure, so what they have done here is they have shown quintiles of blood pressure, mean arterial pressure. So the highest quintile 5 is the highest blood pressure group, the top 20%, and you can see the highest blood pressures are associated with the highest values of stroke volume, heart rate, and cardiac vascular resistance. And then if you look at the panel on the right, it shows that the relative contribution of each one of these is similar. So they are proportionally causing that increase in blood pressure, suggesting that both cardiac output and vascular resistance lead to high blood pressure in these in their data. I think one of the points to note here is that they did not quite comment very clearly about the overweight and obese individuals, and a lot of them, if not most of those, were in the top quintile. So probably a lot of these data is skewed because of that. We recently performed as part of the Hyperchild Net group, and there's lots of colleagues and friends here, which is lovely to see, a systematic review looking at untreated young children and young adults, should I say, and highlighted that there is an increase in heart rate in these untreated primary hypertensives compared to the normotensives, and this is even after, in the lower panel, those who are not obese. So whether it is obese or non-obese, it doesn't matter. And then these data from Professor Litwin group, which shows that there is a trend, there's an increase in cardiac output, which actually increases with increasing levels of blood pressure. So there are ambulatory blood pressure values, which have shown normotensive, there's a pre-hypertensive group as well, and then ambulatory hypertension, which is associating with target organ change. And you can see that the increasing high blood pressure is associated with increasing levels of cardiac output, as mostly associated with stroke volume, but there is actually no real difference in the peripheral vascular resistance in this group. These were slightly 15-year-olds, so slightly younger, but very clear data showing cardiac output changing in these patients. We performed a comprehensive sort of analysis looking at the hemodynamics of primary hypertension and compared them with normotensive children, and published this recently. They were 2/3 of the patients were on antihypertensives, and they were mostly male, 60% were male. But what is quite interesting on the top panel is the steady state blood pressure, so mean arterial pressure. And if you look at the difference between the hypertensive and the normotensive patients, most of this difference is explained by the difference in cardiac output between these patients, but not by their systemic vascular resistance. And if you look at their pulsatile BP, or the pulse pressure on the lower panel, we were able to see that the differences in pulse pressure seen between the hypertensive and normotensive were explained both by an increased rate of ejection, which is shown on that panel F, but also by the aortic pulse wave velocity close to the heart that we measured. So these data suggested that the increased steady state and pulsatile BP are mainly again due to cardiac changes, cardiac properties, rather than arterial properties in general sort of arterial tree. We've also then gone on and shown that when you look at the earliest phase of ejection from the left ventricle in these primary hypertensives, we have divided those primary hypertensives by tertiles of their left ventricular mass. So tertile 3 here has got the highest levels of LV mass and therefore some LVH. We can see that the earliest sign seems to be an increase in the contractility of the heart, so that there is a bigger sort of increase, there's an increase in the ejection fraction which is coming out of this LV even before there are any adverse remodeling happening in their left ventricle, and those groups which have adverse remodeling and LVH are shown in the tertile 2 and 3, and by that time the ejection fraction starts falling. Although the usual parameters we use for diastolic systolic function did not show any difference here. So when we summarize that data, looking at the hypertension phenotype on the top, and we look at their hemodynamics, you can see that there is a change from children, young people, where there's mostly cardiac output, to then increasing systemic vascular resistance before there is stiffening of the artery, which suggests perhaps that with longer duration and greater severity of uncontrolled hypertension, there may be progression from a cardiac to a vascular phenotype with increasing systemic vascular resistance and therefore more difficulties in actually being able to reverse that trend, and that's the problem which our adult colleagues keep telling us. There are very few data though of what happens to these hemodynamics when you actually treat these patients, and this is one, and I suspect perhaps one or two of these, this is one from Professor Litvin again, who has shown by central blood pressure, so those children who had, after a year of conservative management, so non-pharmacological treatment, those whose central blood pressures did not increase and they became normotensive, there was a reduction in their heart rate, there was a reduction in their stroke volume, and there was a reduction in their cardiac output, but no change in their peripheral vascular resistance compared to those who progressed and carried on increasing their hypertension. So it would suggest that if we did manage to reduce and reverse that, then there will be changes in these phenotypes, the hemodynamic phenotypes. This has led us to come up with this suggestion, suggesting where sympathetic drive, sympathetic nervous activity might be coming from, obviously from the brain, acting on the heart, and working in those ways at both the cardiac contractility and stiffening, as I explained, and working on the cardiac output with a lesser component of the systemic vascular resistance in these young individuals. And that builds on some work which Professor Faber, Janos Faber, and Professor Litvin had sort of added, which had introduced the role of visceral fat and these important pathways, including some of those related to the immunometabolic sort of pathways we've talked about. And these are not the only pathways that we know of. We've talked about the genetics, and we've talked about the central role of the kidney in managing these, and these are very poorly understood at the moment. So there are huge gaps in our current knowledge. These evidence base is largely, as I've shown you, small cohort studies in children, young people. There are no experimental data, very few, if any. I think we'll have a talk about one of those subsequently. The control groups are rare, they are very short follow-ups. And this has resulted in impact on how we manage these children. So, both the CPGs that we follow in different parts of the world specify the choice of treatment should be as shown based on the underlying pathophysiology. But apart from chronic kidney disease, where it is quite clear what we do want to do, there is very little data there, and at best we do a pragmatic sort of take on this. And so there's minimal evidence regarding which medication we should use and on what basis, and that's our current sort of state of play in terms of understanding the hemodynamics and trying to then implement it in our clinical practice. And so this is on shaky ground. I'm sort of just suggesting, hemodynamic directed therapy could potentially be something like this. You could have a cardiac driven hypertension where your patient will have a high heart rate or just have isolated systolic hypertension. In the context of obesity or somebody who has an anxiety sort of issue, and that would be based on increasing sympathetic nervous system activity. There are very difficult ways of measuring this specifically. And in those individuals, a beta blocker may be of a much more logical use and far more efficacious, perhaps, based on the data that we've seen. And in others, and of course, when we consider that, we have to think about the known side effects, certainly with the first and second generation beta blockers, but perhaps with this third generation ones, it's much safer. If it was a vascular-driven hypertension, that would be more to do with, which is something long-standing or resisting or systodiastolic, and we would consider a calcium channel blocker in that, or an alpha agonist. And RAS blockers, if we think both of those are there, and of course they have quite good sort of beneficial sort of profile. There are some data relating to this in adults, and this is one data study which has shown using impedance cardiography, and this has allowed us to divide them into high systemic vascular resistance versus high cardiac index. And they're using this algorithm, they have shown that the same patient groups, they were able to achieve more controlled hypertension and better targeted blood pressure in the patients who had hemodynamic sort of shifting. So, in conclusion, there is evidence of a cardiac and large artery component to primary hypertension in the youth, with increased cardiac output being the earliest sign we see in them. Study of hemodynamics may improve our understanding of etiology of hypertension in these, and the evaluation may have some potential implications and could form the basis of a RCT. And with that, I would say thank you, and also.
But on subcellular level, this can also be observed, and these are typically some of the biomarkers we look at that we can measure. But this is just one example of mitochondrial dysfunction, which is also strongly related to toxins and lifestyle behaviors that can influence mitochondrial function or mitochondrial health. And on the right side of that slide, the table 2 is the features that was initially identified as characteristics of early vascular aging. And just scanning through those, you can see that the majority of the points listed there is very strongly linked to any cardiovascular disease condition. The concept then also extended to a life course approach, where several risk factors during early age can contribute to the risk of developing cardiovascular disease later in life. So this is the life course approach, and essentially we would like to intervene at this very early stage, or the primordial prevention that was alluded to before, to really mitigate the onset of cardiovascular disease later in life. So, as I mentioned, early vascular aging was a concept that was established, and it is established basically on the premise of primordial prevention, and to identify those at high risk of developing cardiovascular disease, either with inherent features or genetics, epigenetics, and also those from the environment and those insults we are exposed to due to lifestyle. So if we take a population on a bell curve, there will always be a proportion of individuals on the lower left side and on the upper right side. And those are the extremes they call in EVA, the supernova and the EVA groups. So this is basically just showing this graph in the normal distribution of a population. So for pulse wave velocity, this is what was used as defining early vascular aging. There will be individuals that have healthy vascular aging, the majority will have average vascular aging, and a group that have early vascular aging that develop these arterial structural and functional problems much earlier in their life than someone compared to the other groups. Now, we've heard about the Barker hypothesis earlier this morning as well, and we tried to illustrate this with one of the call to action papers through the Youth Vascular Consortium that you will also learn more about on the last day of the conference, where people are developing, or well, babies or fetuses are developing with a specific genotype and buffering capacity within their arteries in terms of the elastic laminae, and some individuals have a lower buffering capacity, and that is shown in the dashed line here. So during the first decade of life, there's an increase in arterial compliance, whereafter it declines sharply, and then it steadily declines as someone ages. But an individual with natural biological aging will be on the black line, and someone with early vascular aging on the dashed line. So showing that there's already inherently a lower arterial compliance or vascular stiffness profile or phenotype. And this was a table that was also published by Dr. Ingelfinger on the factors involved in perinatal programming. And again, just by scanning the table and looking at those mechanisms involved, we know that these are all mechanisms involved in cardiovascular disease in general, and the mechanisms that are contributing to elevated blood pressure, atherosclerosis, and so on. So we've expanded that concept of early vascular aging and taking together with a life course approach and extending the graph into the early life programming section, as you can see here. And then an individual on the green line will have an ideal life course, not developing any of these biological aging or complications in terms of target organ damage during their life course. So the majority of us will probably follow the blue line, and then there are a group of people developing early vascular aging. And not only is it because of environmental risk factors or exposures during life, but also what happens in the womb when a baby develops. So those are the intrauterine risk factors that can already put someone on the trajectory of early vascular aging, where manifestations of premature vascular dysfunction can start in childhood or early adulthood. So EVA in the youth is something that we had to publish because we get a lot of feedback from reviewers that give us feedback when we talk about EVA in children, that EVA was a concept developed in adulthood, and yes, that is the case. But if we look at the definitions provided in the EVA initially published by Peter Nielsen, it's really talking about the life course and that it starts early. So we thought of developing an expert consensus document. It is accepted now. It will be appearing in the next few months, where we defined EVA in youth as these precursor alterations of small and large arterial structure and function due to risk factors exposure during fetal development, childhood and adolescence, which ultimately results in increased cardiovascular risk, which tracks into adulthood. So it seems quite obvious, but it is not really the case when you try to publish a paper on EVA in children. But interestingly, even though the concept of EVA was first introduced in 2008, in 2004, the paper from the Babalusa heart study is really something that kind of talked to this evolution of EVA, where systolic blood pressure beginning in childhood was a consistent predictor of arterial stiffness in adulthood, especially in those with asymptomatic risk factors. So the findings obviously underscore that something in childhood is already impacting on what will happen later in adulthood, and this backbone of arterial stiffness is also important to note that blood pressure is the main component of pulse wave velocity, and pulse wave velocity is the golden standard for identifying people with arterial stiffness. But early vascular aging is really going beyond just pulse wave velocity. It's not only one measure that we can look at to define biological aging, but there are several biomarkers and measures that we can use. So this schematic is just the crosstalk between small and large arteries, where central systolic blood pressure has an impact on the smaller vessels, and if the smaller vessels are damaged, it can increase the mean arterial pressure that can further put excess pressure on the large arteries, and it creates a vicious cycle of arterial dysfunction and eventually target organ damage. Now we know that children that are overweight and obese have a higher risk of being hypertensive, but there's also a proportion of children that are hypertensive but they are not overweight or obese. So those are certain questions that we need to ask and understand the etiology of hypertension or blood pressure, which is the main component of arterial stiffness. It's also known that from the first decade of life, fatty streaks start to develop within the arteries and atherosclerotic processes start to occur. So again, this is early vascular aging, where we can look at intima media thickness, for example, as a biomarker of early vascular aging that can indicate whether someone is at risk for early vascular aging at young ages. If we look at the blood pressure component, as I mentioned, in terms of arterial stiffness, it was also shown by Professor Elaine Urbina that several indices of arterial stiffness increase or decrease depending on what it measures. For example, the sensibility will decrease if blood pressure increases, whereas other indices of stiffness like pulse wave velocity augmentation index will increase with increasing blood pressure. And this is also observed in children with a higher risk for cardiovascular disease or cardiovascular risk factors. If a child has a higher risk for cardiovascular disease, there will be higher IMT, higher pulse wave velocity, lower distensibility, and all of the other arterial stiffness indices that we can measure. But there are other risk factors beyond blood pressure and adiposity that should be acknowledged and that can contribute to several cardiometabolic insults. And one of those is adverse childhood experiences or exposures during early life, neglect, abuse, household dysfunction that can lead to depression, and that can also accelerate someone's development for early vascular aging and cardiovascular disease onset early in adulthood. And if we look at the mechanism or the pathophysiology of adverse childhood experiences on the artery, you can see that that is a cascade that we see very often linked with high blood pressure or any other cardiovascular disease on the backbone of pro-inflammation. So what is the relevance of early vascular aging in practice? So we've also heard that this morning that prevention should start very early in life for cardiovascular disease, and the ideal is to preserve cardiovascular health from as young age as possible. Now, we know that a lot of funding and a lot of research is going into the secondary and tertiary leg of prevention or treatment. That is where the drug companies make their money. But the primordial prevention really is at the core of any population's health. And this is the only level at which children can be supported in order to preserve their cardiovascular health. And I'm mentioning this paper because if the number of risk factors are increased in a child, so if a child is exposed to unhealthy diets, they are sedentary, they have a dysfunctional household, those risk factors accumulate and it can increase the risk of developing cardiovascular events at a much earlier age. And this paper has shown that a combined Z-score of these risk factors in children can increase the risk of developing a fatal or non-fatal cardiovascular event before the age of 47.7 years. So we mentioned also this earlier in terms of precision medicine or individualized medicine. anyone can, say for example, all three of these individuals have high blood pressure. There is a guideline, so we can treat high blood pressure. But essentially, this is the reality because everyone looks different, everyone has a different story, everyone has a different history of health or disease in their families and exposed to different risk factors. And also, geologically, we all come from different parts of the world, so we have different exposures. So one guideline cannot always fit all the scenarios. But what is really important is that policy really works, and we've seen that in South African studies. I'm sure there are many other examples, but for example, the SALT legislation that was implemented had a population level of 1.2 to 1.4 millimeters mercury drop, and that was only with the first phase of salt reduction in the foods. And also we saw a decrease in the frequency of sugar-sweetened beverage consumption in children after there was a sugar tax implementation post-COVID in South Africa. So just a few points for summarizing early vascular aging in youth, that children and adolescents should be screened regularly to identify and detect those at high risk and can benefit from primary prevention and intervention strategies. Early vascular aging also paves the way to target primary cardiovascular prevention, and it's not a condition or a disease, but a concept to identify those at high risk for accelerated vascular aging. And features of EVA are useful in the detection of high-risk individuals, especially in low-resource settings. So you do not need to have those most expensive technologies to identify someone at high risk, but there are clear signs and characteristics of a phenotype that you can identify a child to help them preserve cardiovascular health. Thank you very much.
Contraction of the descending aorta. This is now understood as a cardiovascular syndrome. It presents numerous anatomical variations, as we will see shortly. In this MRI reconstruction, a typical aortic coarctation is identified with narrow than the aortic isthmus, its most common classic presentation, accompanied by dilatation of the ascending aorta without involvement of the left subclavian artery. In the left reconstruction, we observe a neonatal aortic coarctation with severe hyperplasia of aortic arch, as narrowing of the aorta proximal to the left subclavian artery. This MRI reconstruction shows tortuous and dilated aorta with severe aortic coarctation. This is the case of the patient with aortic coarctation repair as a newborn on his long-term course. And in this MRI, we can see a stent placed in the aortic coarctation. You can see that aortic coarctation is a condition that at the long term involves many variables, which we'll discuss during the presentation. And there are an increased cardiovascular morbidity and mortality in the follow-up despite successful repair in childhood. It has been studied and shown that these patients have a reduced life expectancy with a prevalence of hypertension ranging from 25% to 68%, and mortality in this group of patients is determined by hypertension and vascular disease development over time. Here I present the KOALA and KOAFU studies among the first and follow-up on patients with corrected aortic coarctation over the long term. They analyze the importance of hypertension development even in patients without recurrent aortic coarctation. To me, this study formed the foundation of subsequent research over the years. They show a prevalence of mass hypertension of 25% in patients operating with an aortic coarctation operated without recoarctation, and both studies highlight the importance of arterial stiffness in long-term outcome. The hypertension is the most common long-term complication after completed relief coarctation of aorta without residual arc obstruction. The onset of hypertension is patient with correct aortic coarctation can be related to several factors, which we will discuss. The presence of residual lesion at the site of aortic coarctation can cause hypertension. Therefore, it is essential to highlight the difference between residual and recurrent aortic coarctation. Residual aortic coarctation occurs when immediately after treatment, a significant volume remains, indicating that the treatment only partially resolves it. Recurrent aortic coarctation refers to those who are initial resolution was successful with no significant residual gradient. Over time, the coarctation reappears, often during periods of rapid growth, such puberty. Up to 20% of patients may experience recurrent coarctation during growth. The initial approach to addressing the lesion also determines the difference in long-term outcome and vascular complications. This is closely related to the next point, which is the age at which the aortic coarctation is resolved, because the longer exposures to aortic arc hypertension may cause irreversible damage in the arteries. As I previously mentioned, the anatomical difference of aortic coarctation results in various techniques for its resolution: end-to-end anastomosis, extended end-to-end anastomosis, subclavian flap repair, use of protective material parts, or in the case of pediatric or adolescent patient, resolution without arthroplasty and stent placement. For example, the subclavian flap may affect the elasticity of the segment because there is no aortic tissue. Over the years, this possibility has developed, and we have learned, for example, that the use of protective material is associated with high rates of recoartation and increased risk of aneurysm as shown in the arrow. The timing of aortic coarctation resolution is also related to the likelihood of developing hypertension in the future. Some research that analyzed vascular remodeling in adults with operate coarctation of the aorta and its relationship with the age at approach concludes that the age of correction has no relationship with the subsequent development of peripheral or central vascular remodeling, because coarctation of the aorta is a systemic vascular disorder that progresses to vascular and target organ damage regardless of the age of correction. But in this imaging, we see difference in the risk of recurring antihypertensive medication over the lifetime, depending on the age of resolution, neonatal, infant, or child, and this observation is maintained in other research. Another important factor is the morphology of the aortic arch. Aortic stent could be the cause of structural arterial change and vascular remodeling related to GR stress. The ventricular arterial cavity in the aortic arch allows of normal functioning. However, because of contractile aortic arch morphology, as seen in the imaging, there is a higher prevalence of hypertension. There are functional and structural abnormalities in the arterial wall in patients with coarctation of aorta contribute to hypertension. Activation of aortic vasoreceptors the sympathetic system, activation of heart system, increased arterial stiffness, and shear stress of endothelium may be involved in the mechanism of hypertension. In patients with coarctation of the aorta, vascular activity is impaired, and there are studies that show that the gradient in the aorta may be reduced and the left ventricular mass may be improved, but the arterial structure and function remain abnormal. In summary, the patient with repaired aortic coarctation during follow-up, we must evaluate the possibility of recurrent aortic coarctation, the development of hypertension, cardiovascular risk, associated lesions such as biguspid aortic valve, aortic dilatation, and aneurysm. Thus, we know this patient can develop in the central nervous system. So, for follow-up, the recommendations include measure blood pressure in 4 limbs at each checkup, performing echocardiograms to assess the gradient of the repair site and associated lesions at biguspid aortic valve, evaluated ventricular mass to rule out ventricular hypertrophy. ABPM is recommended annually due to the possibility of high hypertension, which has a prevalence of up to 25% in the population. Imaging studies like CT or MRI are recommended every 5 years in asymptomatic patients to evaluate anatomy and rule out complications. In case of
Arterial stiffness yung sa carotid. Arterial stiffness yung sa carotid. Yung in-workshop natin.
Exercise dating laboratory is recommended to evaluate the blood pressure during exercise, and studies of arterial stiffness such as waypoint velocity are still in a research stage. It is always important to emphasize lifestyle measures like maintaining an effective weight, engage in daily physical activity, following a healthy low sodium diet, and avoiding alcohol. It's important that no specific disease entities have been said of targeting children with their coarctation of the aorta. One hypertension is confirmed in this patient. The recommended medications are ACE inhibitor and beta blockers. So beta blockers are also used because this patient often have aortic dilatation, which also benefits well from this medication. Here is my first treat on the ABPM in patients with repaired coarctation of the aorta, where we can see a significant prevalence of mass hypertension and nocturnal hypertension, which reinforce the importance of ABPM in this population. Here I share with you our experience in patient follow-up with coarctation of the aorta corrected in the hypertension clinic. It was a poster presented at each Congress in 2024 based on the retrospective analysis of 142 patients. Our population has 28% hypertension amongst those under 8 years of age, and it increased to 46% among the elders. Considering that international reports that indicate that the evolution toward hypertension in this population is progressive. Overweight and obesity increase over the years too. It's very important to talk about physical activities and cardiovascular prevention measures in this population. And in this work presented in 2023 at the Argentine Congress of the Society of Hypertension, the longitudinal follow-up of the control patients showed that 50% developed hypertension at almost 3 years to follow-up. And during that time, 62% of patients with hypertension had achieved control, demonstrating the importance of longitudinal follow-up. The follow-up of patients with repair aortic coarctation, long-term adherence, the study of ambulatory leisure phenotypes, and endothelial and vascular chains remain subject of study and ongoing challenge. Thank you very much.
Kaso hinawakan ko na.
So hypertension is very prevalent in children with CKD, and depending on the underlying kidney disease and the stage of renal function or CKD, there are between 50 and 80% of patients with elevated or hypertensive blood pressure values.
Bakit kaya maraming mask mo? Bakit kaya maraming mask hypertension?
And the kidneys play a central role in the regulation of blood pressure. Together with the cardiovascular system, adrenal glands, and the central nervous system, they regulate cardiac output, fluid volume, peripheral vascular resistance, and are responsible for the development of hypertension. So, going a little bit more into detail in CKD, blood pressure is read by cardiac output and total peripheral resistance. And in uremia, by chronic PTH elevation, increased sympathetic tone, endothelial damage, we have increased vascular stiffness, vessel diameter is reduced by vasoconstriction, and we have an activation of the RAS. We have the renal disease with renal artery stenosis, meteoscars or cysts, also activating the RAS. We have reduced nephron mass in renal insufficiency with sodium retention, oliguria affecting fluid load, and also resulting in increased blood pressure, and the central role is mainly the RAS activation. So RAS activation is mediated by the key player angiotensin II, which goes to the AT type 1 receptor, which mediates vasoconstrictory, fibrotic, inflammatory, and antinatriuretic action. But there's also a kind of a protective arm of the RAS mediated also by angiotensin II, but also by some metabolites or fragments. And it's going to the type 2 receptor and other receptors as well, which mediate vasodilatory, antifibrotic, anti-inflammatory, and natriuretic effects. So the RAS is not always bad. Activation or of the angiotensin II receptor mediates aldosterone secretion, has a direct tubular effect, and increases renal medullary blood flow, which results in sodium retention, have afferent arterial constriction, increased renal vascular resistance, increase in intraglomerular pressure, which results in increase of filtration fraction, also in sodium retention. So hypertension results from renal disease, but is also a cause of renal disease, as we just heard. And just trying to bring these together. So if you have hypertension, you have increased glomerular filtration, which induces proteinuria and nephrosclerosis, also increasing protein excretion, resulting in a reduced renal function, and this again is driving hypertension. So you have a vicious circle between hypertension and renal disease, keeping it growing. So the main factors are hypertension and proteinuria and RAS, but there are also other factors influencing kidney disease progression as oxidative stress, smoking, diabetes, hypoglycemia, acidosis, lipid metabolism, atherosclerosis, uremia-induced calcium phosphate, disturbances of metabolism and PTH increase, anemia, and the genetic background and underlying renal disease. But we will now concentrate on hypertension and a little bit on proteinuria because one cannot come without the other. Hypertension and proteinuria have been shown to be independent predictors for the risk of chronic renal failure in the general population and for the progression of chronic renal failure in adults as well as in children. And that's a little bit more detailed flow chart. So systemic hypertension increases intraglomerular pressure, proteinuria, and proteinuria exerts some pro-inflammatory and vasoactive signaling, and at the end this ends up in a dysbalance between collagen matrix protein synthesis and tissue protease activity, ending up in matrix deposition and fibrosis, which induces tubular interstitial hypoxia, means reduced nephron mass, and then you end up here again with increasing glomerular hypertension, and you also have direct effects of vasoactive signaling on glomerular hypertrophy and pressure. And this vicious circle can be blocked by blocking the RAS system, and it's not only by lowering intraglomerular pressure, but also by exerting some anti-inflammatory effects. And there's one landmark trial, actually, it's the ramipril efficacy in nephropathy trial, which showed in adults with proteinuria non-diabetic CKD that ramipril treatment reduces the risk for kidney disease progression, significantly compared to placebo, but that was not only due to a better reduction of blood pressure. Actually, the difference was not so large between ramipril and placebo group, but due to a significant decrease in proteinuria. And there are more studies showing that ACE inhibition reduces protein and the overall risk for composite endpoint, mainly in these studies, of halving GFR, 50% loss of GFR attaining end-stage kidney disease. And also in two meta-analysis, it could be shown that the overall risk is reduced. However, has been shown that there's also some impact of proteinuria. So the risk reduction is in few studies significantly better in patients with proteinuria. So what do we know about blockade of the renin-aldosterone system in children with CKD? And there are, for example, data from the TICKET study with 850 participants, and the risk was adjusted for age, male sex, glomerular diagnosis, GFR, nephrotic range proteinuria, and other risk factors, and it could be shown that RAS inhibitor use reduces the risk of renal replacement therapy by 21% to 37%, compared to other antihypertensive drugs. And in the 4C study, it has been shown the other way around. These were patients aged almost 40 years with a mean GFR of 27 ml, and there were two groups matched. Patients where the RAS inhibition was discontinued due to increased creatinine, hyperkalemia, or symptomatic hypertension, and they were compared to patients with ongoing RAS inhibition, and the discontinuation of RAS inhibition in children with CKD was associated with an acceleration of the decline of GFR. Okay, but what should be our blood pressure goal? And these are data from adults, and nicely shown that there's a direct linear correlation between blood pressure control and GFR decline, with the fastest decline in those patients with untreated hypertension. And you can now conclude that it would be best to have a tight or a blood pressure control as good as ever possible to preserve kidney function. So what do we know about intensified blood pressure control? And these are data from the ESCAPE trial, where patients with RAS inhibition or at the ACE inhibitor ramipril at a fixed dose of 6 milligrams per square meter per day, and were randomized to conventional treatment, which is the 50th to 95th percentile, or intensified below the 50th percentile, and the blood pressure value we evaluated was the mean arterial pressure. It showed that patients with intensified blood pressure had a significantly better renal survival and that the risk was significantly decreased. And this is also shown by a meta-analysis of 11 trials. These are pediatric and adult trials combined. And there was also overall a risk reduction for end-stage kidney disease and the composite outcome. But when this was divided into patients, subgroups without baseline proteinuria and with proteinuria, it's the case that patients with proteinuria have a benefit significantly, while those without proteinuria had no significant benefit. And there was a 10 millimeter mercury reduction in systolic blood pressure, and it resulted in an overall reduction in the risk of kidney failure of 22%. So these findings were incorporated in the recommendations of the European Society of Hypertension for blood pressure targets in children, though in general it's recommended to target for blood pressure below the 90th percentile for age, sex, and height-specific percentile, but for chronic kidney disease, the percentiles are lower. It's for Europe, the 75th percentile in children without proteinuria and the 50th percentile in children with proteinuria. And 24-hour ABPM is strongly recommended, as these recommendations are based on ABPM measurements, and the goals in the European guidelines for ABPM and casual BP are the same. In the American guidelines, the threshold is lower, it's 50th percentile irrespective of proteinuria, and that's very similar to the KDIGO 2024 guidelines, where it suggested that children with CKD should have an ABPM level lower than the 50th centile, or of a systolic blood pressure in the range of the 50th to 75th, related to age, sex, and height, unless patients suffer from hypertension. And renin-angiotensin system inhibitors can be used. So what antihypertensive agents do we have? So I think we have a lot of experience also with some of these drugs are not licensed for the use in children. First line drugs are RAS blockers, calcium channel blockers, diuretics, and beta blockers. Second line vasodilatators, adrenergic blockade, potassium-sparing diuretics, and central nerves acting agents. And of course, chronic kidney disease, microalbuminuria, post-transplant hypertension, ACE inhibition or RAS should be considered due to the pathophysiological action. There's some substances in the pipeline where which have an effect on blood pressure, but also have some neuroprotective efficacy. But I think for the sake of time, and because some of these
Effective
will be
talaga.
addressed
Nalay ko
in
na
other
sa
talks. There will be a talk
Yan
on
yung nakakontrol ng
SGLT2
BP ko.
inhibitors,
Nung pinart
and
mo
there
siya
will be also a talk on new antihypertensive
ARB
drugs. So I think I will skip this.
Effective talaga siya.
We'll just go.
Oo, sayang hindi niya discuss.
Just to my last slide with this overview. So there are some very interesting substances maybe in the future, but we then still have to see whether they are also safe and effective in children.
Yung army pala.
And potential antihypertensive drugs for children with added value, which will be available, maybe licensed in the near future, maybe SGLT2 inhibitors and non-steroidal MRA. There are both studies on the way. And for special kidney diagnosis, IgA nephropathy, or FSGS or Alport, also sparsentan might be an option. So, in summary, the kidney is victim and culprit in hypertension. Renal hypertension is mainly driven by the RAS activation and altered pressure natriuresis. It's an independent risk factor for renal disease progression, and we can protect the kidneys by blood pressure control, and by RAS inhibition we can prevent glomerulosclerosis. We know that we have a high prevalence of uncontrolled hypertension, so we have to be very careful with our patient and to check blood pressure regularly.
73 shot without protein.
I think I missed something, sorry. So, but we also know that ongoing or recurrent proteinuria is a risk factor for progressive renal failure, even with excellent blood pressure control. So if you treat patients with DKD, please also consider optimal antiproteinuric treatment, and maybe you also may have to consider combination therapy. And there are new antihypertensive and renoprotective drugs underway, but data on long-term efficacy and safety data are still needed. Thank you very much.
Thank you, Mary. Thank you for a very nice summary. And I think we have time for a few questions. Right, let me start. Can you tell us, how did you guys come up with the recommendation for 50th percentile and 75th percentile for casual blood pressure?
Well, that's extrapolated actually, because we, for the evaluation of the ESCAPE trial, we looked at the MAP.
So basically what I'm saying is that the recommendation for casual blood pressure right now are based on ESCAPE trial that did ambulatory blood pressure monitoring, right?
Yeah,
right.
Actually it is.
So the bottom line, I think we don't have a really good data to know what really should be our casual blood pressure recommendation, because ABPM and casual may be not the same.
No, but what's similar when we did the analysis, but the main outcome was the ambulatory blood pressure measurement.
Dr. Flynn?
And I didn't mention HOTKIT because it was a cardio.
So if you look at the renin-angiotensin-aldosterone system, blockade, use of AT1 receptor blockers shifts the effect of angiotensin to the ETB receptors, which have more anti-fibrotic, anti-proliferative, and beneficial effects on that. It's a good half of the system. So, what are your thoughts about favoring, ARBs versus ACEs to maximize the beneficial effects of the other side of that system?
Yeah. So in fact, we changed our clinical practice from ACE to ARBs because the side effect to the cuff is less, which might also be a problem in smaller children. You never know if it's an infection or not. And we also saw that we had an escape phenomenon in the escape trial, that after 3 years proteinuria reoccurred, and that might be also a reason to change from ACE to an ARB, because of the risk of this aldosterone rebound is a little bit less.
So, thank you, Elke. I just really wanted to add a comment to what Mark was asking. So, for the same kidney patients, we do have a trial to show that a lower office systolic blood pressure done in a standardized way is helpful. So, I think what the clinicians need is not two separate targets. They need an integrated target, and we saw some data for that. And also, your data from the CKID cohort already shows that if you target a lower office systolic, then the chances of having masked hypertension are very low. So I think putting some of those things together, and not everything can be an RCT, and certainly there are questions around equivalent studies and how useful they are. A lower target for both of those is probably the right way to go.
Yeah, I think the correlation in this point between the casual BP and the ambulatory is not so big, but it might be not 100% correct to say it must be the 50s, but we can work on it.
But I can tell you that maybe it's a hard question, but don't worry. In the United States, we adopt the same recommendation. Okay. Any other questions? So thank you very much.
Hi, I will introduce Dr. Mark Meekness, Professor of Pediatrics, University of Cincinnati College of Medicine, Director, Clinical Translational Research Center, Cincinnati Children's Hospital Medical Center, Division of Nephrology and Hypertension.
Well, thanks again. So let me start with this slide. It's a old study, right? So it's 20 years old. This is Napartic data, and you can see the prevalence of hypertension in patients on maintenance dialysis. So just pay attention to 2005, about 50%, right? You follow them for a few years. If they're still on dialysis, the prevalence is still about 50%. Now, that's after this study. There have been a few more studies looking again at for prevalence of hypertension, and this is very nice summary published by Fabio Vialonga in 2018, looking again at prevalence of hypertension, and you can see here, this is the prevalence of hypertension, right? But it doesn't matter how you define it, right? You can define it by controlled hypertension, untreated, uncontrolled, patient taken on antihypertensive, or uncontrolled hypertension in treated patient. The prevalence is about 50%, right? 60 to 70, so it's quite high. And this study has been done between 2005 and 2017, something like that. There are two more studies that I think very good, and this come from International Peritoneal Dialysis Network, the first study, published in JASN more than 10 years ago. And you can see that in peritoneal dialysis, the prevalence of uncontrolled hypertension was about 45%. The more recent study from the same group, but now using International Pediatric Hypertension Network, that was just published in last year, NKI report, showed that 55% of patients had on maintenance hemodialysis had uncontrolled hypertension, and the subgroup of this patient had ambulatory blood pressure monitoring, and you can see here that 81% had uncontrolled hypertension. Now, of course, doesn't matter, it was 2005. Now we're back to 2025, right? We are not doing a good job controlling blood pressure in patients on dialysis. Okay. So what are the causes of uncontrolled hypertension? Of course, we all know. And by the way, most of us here are nephrologists, I understand, right? If you look here, this is one of the first studies that we did through Pediatric Nephrology Network Consortium, PNRC, and we just look at different centers in the United States. This is a 10 dialysis unit. We decided in 2006, get like September of 2006, and look at all blood pressures that been recorded during that month in all these centers, and you can see that pre-dialysis, the first week of dialysis, mid of dialysis, and of course post-dialysis session. So it's all been done, and you can see the difference when you at the beginning of dialysis session, prevalence of hypertension was 59, and after end of dialysis session, 3 to 4 hours, the prevalence 42%. So of course we remove fluid, blood pressure got better, right? Nothing new here. A couple other studies. This again a study for Fabio, published in 2015. He looked at diabetic weight gain and blood pressure. You can see nice correlation. Very similar study was done again another study, but in this second study they used ambulatory blood pressure monitoring. And what you can see here, pre-dialysis, causal blood pressure, the prevalence of systolic hypertension was 38.5, diastolic 23. They look at post-dialysis session. Again, it's significant improvement to about 7.7%. But then in 24 hours, right, using kBPM, prevalence goes up. And right at the end, before next dialysis session, we had the same result. So it's again back to 38%. So definitely we see the shift of the fluid, and that's what leads to change in blood pressure and change in prevalence of hypertension. Now, other causes of uncontrolled hypertension, this again from an original study, and you can see here that baseline hypertensive patients had higher level, receiving antihypertensive medication, leg raise, younger age, acquired kidney disease, hemodialysis versus peritoneal dialysis. It's all these factors associated with worse hypertension. Other causes, maybe arterial stiffness, using of EPO, steroids, calcineurin inhibitors, secondary hyperparathyroidism, or previous renal transplant. All these factors have been known to associated with higher rate of hypertension. I will focus more on the most recent study because I think this is a very important study that from KI. And you can see this is table looking at general mixed model analysis of factor associated with systolic and diastolic blood pressure. Okay. Again, very similar to 2005. You have younger age, number of antihypertensive medication, acquired kidney disease, and dialysis vintage. But here they use it hemodialysis versus hemodiafiltration. So a patient on hemodialysis did worse than a patient with hemodiafiltration. But one important advantage of this study versus all other studies is you're looking at interdialytical weight gain, okay? And that we'll see here, very significant association. The more interdialytical weight gain, the of course more going to be hypertension. And for each 1% increase in relative interdialytical weight gain was associated with 19% increase in systolic and 9% increase in diastolic blood pressure standard deviation score. So definitely volume is important. But they also look at what factor associated with interdialytical weight gain, okay? And you can see here, not surprised, those with urine output had better outcome, or those with diuretic use, very interesting, also had better outcome. And also no surprise that higher dialysate sodium or dialysis vintage, again, hemodialysis versus hemodiafiltration were all associated with a higher interdialytical weight gain. So what to do, right? So I guess we know what to do, right? But first we need to define blood pressure targets. And that's not easy.
In 2005, KDOQI guidelines said optimal systolic and diastolic blood pressure should be below 95th percentile. For some reason, in 2021 KDICA guidelines, there is no recommendation for pediatrics where we should be, okay? 90th percentile, 95th percentile, 50th or 75 percentile, we don't know, okay? Basically, there is no studies to support optimal blood pressure targets in children on maintenance dialysis right now. In any case, again, I go back to another review by Fabio when he looked at steps to achieve blood pressure, right? And you can see here that dry weight management, sodium intake, sodium and fluid removal by dialysis, that's all very important. But what they all indicate volume control, right? And you know, if you look at all other studies, basically the consensus that about 90% of our management related to blood pressure should be volume control. Using of other methods like using blood pressure medication, that's 10%. So think about it. So another input, if you're going to go to this article, I really like this because it's, again, this is blood pressure and volume management in dialysis, conclusions from KDICA Controversy Conference. And they just give you multiple steps how to assess dry weight and how to manage hypertension. So the first step is a dry weight and volume assessment, okay? Again, this is a mainstay. You know, we have so many different tools, but again, we have to go back to basic, okay? And make an assessment, physical assessment, look at the history, and this is very important, okay? Blood pressure, again, I'm not completely agree with this because of the previous study I show you that higher blood pressure associated with volume, so I think we still have to think about it. If blood pressure is poorly controlled, we always have to go back and look at the volume and manage fluid management. But then they comment on this test, which is the lung water ultrasound, okay? And probably this is the most sensitive and specific test looking at fluid management in patient on dialysis, okay? So what it is, water accumulation in the lung, interstitium thickness, and intertubal septa. The thickening produces a reverberation of ultrasound beam and generate visible bundles, narrow basic going from probe to the edge of a tomography screen. And these bundles are true ultrasound equivalent of B lines. So B lines, you can see here, right? And there are studies in adults show that probably 3 lines will indicate overfluid. Some study will say 5. There are very few pediatric data, only maybe a couple, very small studies, but again, I did between 3 to 5 lines. If you see them, probably a patient has fluid overload. What about bioimpedance? Again, this is a nice tool. Again, it tells you different, basically it's an electrical current looking at different tissues, and we have normative values for this, and the machine is available, but it's not cheap. It's about $20,000, at least in the United States, one of those machines, okay? What about relative blood volume monitoring? Many of us use Critline, right? It's a good tool, but I think the most important is not just single one tool, another tool, the combination of tools. That will give us probably the best assessment of patient dry weight and volume status. Second step is fluid and salt restrictions, right? There have been multiple studies and meta-analyses, and it's difficult. The difficulty is adherence, right? Because take our adolescents, right? They're just not adherent. And you can see the first study, 16 studies, second is 23 studies. It's just poor adherence, okay? But we still need to talk about it with our patients, with the families, okay? KDOQI 2005, low salt intake with less than 2-3 grams of sodium per day. So that's a current recommendation, probably very reasonable. The next is dialysis prescription. This is step 3, and again, we can talk about sodium, right? High dialysate sodium increases intradialytical weight gain, but at the same time, it prevents hypotension during dialysis session, right? So really, we have to think about it. There are multiple studies now in meta-analysis in adults actually saying that low salt in dialysis is probably not good. Okay, and one of the big studies in adults, like meta-analysis, showed that sodium 138 and above was associated with better outcome as far as overall mortality data in adults. Calcium is important, magnesium is important, so I think we're all aware of these electrolytes. Hemodifiltration is better for blood pressure control than hemodialysis. This is data from 3H study with Roxana Shrouf and the first author, and showed that basically, suggests that hemodifiltration is better, and this correlates with improved blood pressure control and clearances on hemodiafiltration. Now, there's this another study from 3H using 24-hour blood pressure monitoring, and you can see here the differences in blood pressure control and maintaining blood pressure in the hemodialysis versus hemodiafiltration. Okay, and clearly those on hemodiafiltration 24-hour map was just very nicely controlled. So possible mechanism for better hemodynamic stability and blood pressure, increased convection, which might lead to a little bit more sodium removal, less intradialytical weight gain, and better blood pressure, more efficient removal of middle molecules, allowing better and more lasting hemodynamic control, maybe improved some kind of inflammation, less arterial stiffness, and dialysate is naturally cooled, which itself may reduce the rate of dialytical hypotension compared with standard dialysis. Frequent dialysis and fluid overload, of course, this is what we do, right? So this is our 3 days per day, week, and we already saw at the beginning few studies showing what's happening with blood pressure and weight fluctuation, right? Of course, 5 days per week is better, we think, right? And that's just more physiological. Right? Decreased fluid overload will allow for gentle ultrafiltration, resulting in better blood pressure control, better cardiovascular health, and improved patient well-being. I go back to a study that was done by Michelle Fischbach more than 20 years ago, right? 5 oligonucleotide dialysis patients, LVH and poor cardiac function on these patients, okay? Decrease shortened diffraction and reduce therapeutic compliance. So what he did, he looked at the standard hemodiafiltration 4 hours for 3 times a week, and change it for 3 hours for 6 times per week. And here's the result, right? Blood pressure is better. You can see here shortening fraction is better. Right, and LV structure is better, right? Interventricular septal increase, and also diastolic function is better. Okay, so it's nice. So this is our study. What we did, we look at the short, frequent 5 times per week center hemodialysis versus 3-day per week treatment, and this was a randomized crossover pilot trial. Again, this is from NRC, and the reason why we did it, because the previous study just didn't control for total time of dialysis. So we tried to control, okay, everybody will get 12 hours of dialysis per week, but some of them will have it through 3 times per week, 4 times, and another 5 by 2.5 hours. Okay, so we control for basically for time. And that's what we see, right? Number of days with or without fluid overload, which define more than 4% of weight gain. In the red, basically those who had, more fluid overload, 4%. And you can see that on the left, 3 times, on the right is 5 times. Definitely we have better fluid control. And that was translated to better blood pressure and less use of antihypertensive medication. Other consideration for controlling of hypertension is blood pressure medication. Okay, again, this is our old study from PNRC, and not surprising that we are using ACE inhibitors and calcium channel blocker more than any other medications. That's our first line of therapy. But also remember that blood pressure medication can be removed by hemodialysis, right? ACE inhibitors largely removed, ramipril 20-30%, and enalapril 35-50%, except fasenopril. Okay, ARBs and calcium channel blockers are not dialysable. Okay, so beta blockers like atenolol, metoprolol are highly dialysable. Okay, propranolol or labetalol and carvedilol are not dialysable. So I think when you start patient on blood pressure medication, always think about which one is dialysable and which are not dialysable. Optimal timing also should be in consideration, but it's still debating because KDOQI 2005 said at night is preferable. KDOQI 20, it should be individualized, whatever it means. And also very interesting, discontinuation prior to dialysis session is not advisable, okay, because the effect is unknown. So again, I'm going back to the same study from KI report, and they look at what drug is better. In their study, 62% of the duration had antihypertensive medication, approximately 2 blood pressure medications. Again, calcium channel blocker, ACE inhibitors were used a lot, but beta blocker 45% and diuretics in 70%. So remember, this is hemodialysis patient. They still use diuretics, which is quite unusual, right? But what they looked and saw that, and did multiple regression analysis, and use of beta blockers was associated with better blood pressure control than other classes of antihypertensive medication. And also, among those who were prescribed diuretic, urine output was 2-fold higher compared to those who were not. Of course, all these patients had some urine output, so that's why they were prescribed diuretic. For those who are anuric, we're probably not going to use it, but it's very interesting. These data are quite novel, and we have to rethink, what to do with diuretic, what to do with beta blockers. Are we reinventing the wheel? And I can show you this is data from early age of hemodialysis treatments, right? 1969. Look at the blood pressure control. 95% of patients had blood pressure control. Of course, it's adult study, not pediatric study, right? But this is what happens over our progress in treatment of patients on hemodialysis, or I would say progress, right? So, first of all, from approximately 12 hours of dialysis session, which is definitely not practical, we went to at least 3.5-4 hours. And you can see here, sodium diet. We now use a lot of processed foods, right? Sodium is up. Now, and 80%, we also use a lot of sodium remodeling, and we're not using, some centers use, for example, 140, 142 in hemodialysis for sodium, so that's probably too much. And again, that all led to the prevalence of hypertension from 10% to 80%. So I don't know if we're doing a good job, but again, you saw that we, as pediatricians and pediatric nephrologists, have any improvement over the last 20 years in management of hypertension on hemodialysis. I didn't put much here on this talk on the peritoneal dialysis because I think blood pressure may be a little bit better control, but still not optimal. Sorry. Summary, uncontrolled hypertension is frequent in children on dialysis. Accurate assessment of dry weight is initial and critical step. Avoiding fluid and salt overload is the most important step in controlling hypertension, and controlling hypertension is critical in preventing cardiovascular disease, the most common cause of death in children on maintenance dialysis. Thank you very much.
Summary, I'd like to make a question to Dr. Yes.
Thank you, Mark. We all agree that volume is our so it's most important factor.